difficulties. Here's our agenda for today. We're going to kind of do our introduction right now. We're going to talk about what the enhanced FMAP is, how we're spending it, kind of what some of the highlights of that spending plan are, how you can get involved, and then we're going to answer your questions. So, and on that note, the question and answer session. So we'll do that at the end. There's a button that says Q&A. You click that, a box will pop up. There's a place for you to submit your question. You can feel free to submit questions at any point in the webinar. However, we are going to hold all questions till the end and answer them kind of all at once. So again, Q&A for any questions about what's being presented. If you're having technical difficulties or something else is going on and you need to chat with me, go ahead and hit that chat button. So, and with that, I'm going to hand it over to Pam Smith, the director of our Division of Community Alternatives.
Thank you, Kelly. So I know there are some of you that have attended the participant sessions earlier, the one we had last night, and then we had one just a little bit earlier today. So, you know, the presentation is really the same, still going to be a very high level presentation, just to kind of give you all an idea of some of the details about the enhanced FMAP and where we're going and what to expect next. So what is the enhanced FMAP? So the government matches every dollar Kentucky spends for HCBS services. That's the FMAP. The American Rescue Plan Act passed in the spring temporarily increased that match given to states. So it's an additional 10%. And that's what you'll hear referred to as the enhanced FMAP or the funds through the ARPA. So normally with the funds, so that allows us, what that's going to do, that additional 10%, that we can draw down those funds and reinvest it to enhance and strengthen our programs. So Kelly, if you'll go to the next screen. So the amount, we know we're going to receive several $1 million. The amount will vary though based on a couple of different factors. One, it'll be based on the amount of money that we spend. The other is it's going to be based on the type of the service. So benefits, which are the services to the individuals, get a higher match. So we get a 75-25 match on those services. Administrative, which are the expenses that are necessary for running the waiver. It's things like program management. Those are a 50-50 match. So depending on what category it falls in for the spending, also in fact it will affect the match. Just to clarify, we did not receive the money in one lump sum. I know that was a point of confusion early on, that we had identified how much we were going to get and that CMS had given us that money and that we had it just to allocate. We have to actually draw down the funds quarterly, as well as we have to provide updates to our spending plan and our narrative quarterly. Our first one of those was due in November, and we will be doing the next one actually is due in January. And they gave us a little extra time on the first plan update. So Kelly, if you can go to the next one. Oops, go back one. Okay. So how we categorized our initiatives and then assigned a initial percentage of how we plan to spend the money. So you'll see workforce development is the highest percentage, 35% of that. And I'll go into on the next slide a little bit more what is covered in that. But, we realize that improving services and maybe changing some of the services will be great. But if we don't have a workforce to deliver the services, really doesn't impact anybody's lives. So we have to have some strong initiatives towards workforce. Improving ease of and access to HCBS. We'll talk a little bit more about that on the following slides, but that's where you're going to see us looking at services and rates. Crisis services, we had a really good question asked last night about crisis services. What is a crisis service? So these are related to typically what you would think of with some of the mental health or behavior, where an individual has a crisis, and they need, either they have a short hospital stay, a long hospital stay. There's intervention that needs to happen there, but we also realize that individuals have crisis of other types. There can be a change in a caregiving situation where you may need emergent respite. There may be times where an individual who previously really didn't have many medical needs has a new diagnosis or has a significant medical event, and they need some additional services. And these are all intended to help transition individuals back from like an acute setting back into the community, as well as looking at addressing services directly in the community. We're working with our state plan, behavioral health services, looking at mobile crisis units. They have a grant that they are working on there. So we're working in conjunction with them, as well as working with BDID in conjunction to develop some of the initiatives that were already in place, like the 988 mental health line, similar to what you have for 911. Then there's always, tools and transformation. We want to keep up with our tools. There'll be enhancements to MWMA, potential new tools. And then the smallest amount is project support, although I will say it is a very critical support, just because of the reporting needs to CMS, the quarterly plan updates, as well as they will help us with stakeholder engagement and planning and scheduling. Things will be able to provide Kelly support there. So workforce development. So initially, we want to look at incentive and recovery payments to help waiver provider agencies. We know that we're not going to be able to just enhance rates or give a rate increase across the board until we have a payment methodology in place that supports that. CMS has been very clear about that, but we also know our providers have taken a significant hit over the last couple years, as well as the workforce shortage is not a new problem to COVID. It really was happening pre-COVID, and COVID has just made it worse. So looking at what can we do to infuse funds just directly initially. What can we do for training for our direct support professionals? This also is going to include our PDS participants and the providers that support them, as well as training of ancillary staff, so that we can avoid. On the call this morning, we were talking about when you call with a question and you get kind of batted around like a ping pong ball, with nobody really knowing the answer. So we're working to create resources and guides for all of the individuals that, whether they work in DCBS, they work with state plan, or they're one of our call center representatives, that they have resources at their fingertips to help them answer questions or to connect the individual directly to the correct person. We want to look at career advancement paths for DSPs. I think a lot of times it is the job of a DSP. People are like, number one, what is that? And then, or they're, oh, well, you do what somebody does in a hospital or in a nursing facility. When, in fact, the job is much, much different. You're involved in every aspect of an individual's care, sometimes very intimate aspects. You help them with toileting, or you actually help them with bathing, but you also become a champion for them, and you work on their goals and training and helping them to integrate into the community, and to really be as integrated and successful in what they want to do and in their life. So you really become more of a champion, I think, of the individual. And a lot of times I think they become almost family for the individuals. We want to talk to the local vocational schools and local colleges about developing a direct support professional, maybe I should just say DSP path, so that they can come out of high school in the vocational program, and maybe they're going to nursing school, for example, but they have a I'm sorry, training that has prepared them to work as a DSP while they're in nursing school, or begin a career that can last, that can become a lifetime career as a DSP. Um, the last thing on workforce development, and we've had some initial meetings on this, is the creation of a central employee registry for DSPs and PDS employees. If you vision, this is something kind of like would be Indeed or LinkedIn. What we're thinking about is kind of a website where individuals who want to work as a DSP, but maybe you're not connected with a certain agency, or they don't really know where to go to get started for employment, they would be able to go on this system, give information, kind of upload their resume, if you will, give some details of, I live in Franklin County, but I'm willing to travel to, Fayette and Jefferson or Anderson County. I'm interested in providing services, Monday through Friday, Saturday and Sunday. I'm interested in providing evening or night services, so that then our traditional providers or our participants who are looking for employees could go and see this employee that, hey, they may fit what I'm looking for. Their training and background checks, that information would be able to be uploaded and retained there, just to facilitate that, so that we can decrease on any of that having to be repeated. But really looking on how we can be innovative there. And we're working with a couple, looking at a couple other states that have done something similar to this, to try to not reinvent the wheel, but excited about this opportunity because I think it will help connect people. Clicking on the next one. Okay, so improving ease of access. This is where I talked about the rate study and the review of our service menu. One important note is that we have to guarantee to CMS, as part of receiving these FMAP funds, we have to guarantee that a rate will not decrease below what it was on April 1st of 2021. We know that most of our providers have not had a rate increase, some of them in over 15 years, if not 20 years. So we know that our rates likely are all going to be increased. So we weren't really anticipating a decrease, but that is something that we had to guarantee CMS. As far as services, what we will do, we will look at them, and if there's some services that can be shifted more to the state plan, or it's available in state plan, shifting some of that around to allow for more dollars for the services that truly can only be provided in waiver, as well as cleanup of a couple of the waivers had some services in them that had never been provided. They weren't included in the regulations. There wasn't a rate for them. So we're going to clean that up, because really those weren't services that were available or being used to those individuals. We were going to look at the management of the wait list. So in particular, Michelle P. has grown to be quite large. We want to look at, is there a way that we can develop an emergency process for Michelle P? How can we triage individuals on the waiting list to see what services they could be getting now? Is there another waiver they could be getting services in? Is there a state plan service that would meet their need? 70% of the individuals on the wait list actually are Medicaid eligible at this point in time. And a large percentage of the individuals are children. So looking to, are they eligible for school-based services? Are they eligible for K-CHIP? Connecting them through to our KI HIP program to assist with, parents that are paying the insurance premiums, to assist with them getting some financial relief of that, because they have a child that is Medicaid eligible that makes them potentially eligible for those benefits. Better connection of applicants and participants to all resources that can meet their needs. This we talk about the no wrong door approach. So when that application is put in, looking at some of the social determinants of health, looking at food security, looking at, do you have trouble paying your electric bill? Do you have trouble paying your water bill? So that we can not only connect you to waiver and Medicaid services, but can provide links to other services that are truly important to the health of the individual. Initially, we are going to have a pot of money that will cover the cost of background checks for PDS employees. Right now, this is a huge barrier, in particular for individuals in HCB. The rate is so low. It is the lowest of all of our personal service rates. I think about 1052 is about the max rate they can provide. So we want to give some immediate relief there, but looking long-term for the rate study to look at how the rate can be inclusive for all providers to cover that cost. We also will be seeking a statewide financial management vendor to standardize delivery of the financial management services for PDS. We are in the very beginning stages of this. There'll be more information that comes out about this. Potentially, we will issue a request for information first, just to get some increased stakeholder feedback, but there'll be more to come on that. But we right now, this is done, and it's our ads and our CMHCs, but it's an additional service that they have to provide. Sometimes it causes them to not be able to provide as much case management as they would like, just because the additional strain of doing both services and the administrative burden. So really looking at, what can we do to standardize that across the state, and really give some more bandwidth to our CMHCs and our ads to be able to focus more on service delivery. So crisis services, I mentioned a little bit earlier, the 988 initiative, as well as mobile crisis, some in-home care, some transitional services that could include, evaluating for even a residential type home that served as a transition from that acute setting before they went back into either their family home or a residential setting, and looking at crisis respite. Tools and transformation. So looking at how do we make telehealth permanent following the end of Appendix K. We do plan to include telehealth. However, we realize that eyes on is very important for this population. It's very easy for an individual to tell you, to put on a good face on camera or on the phone to tell you, oh no, I don't have any trouble walking in my house. I don't have any trouble getting my bath, or yes, I have enough food. But when you're in that home, you can see what's going on right in front of you. You can smell what is going on. You may see that there's nothing in the refrigerator. You may see bruises where they have fallen multiple times. So we believe that that face-to-face care is very important. We're looking at increasing the availability of remote monitoring and assistive technology to help participants live in less restrictive settings. There are some individuals that need a little more assistance just with monitoring, but with assistive technology to help with their medication management, some remote monitoring that would connect them to their physicians or their healthcare providers, that they really don't need a lot of other services outside of that. But we want to look, how can we expand to make individuals more independent and to help them be safe in the community. So I apologize. We have some feasibility studies that will begin in the beginning of the year, looking at our SMI, so our serious mental illness, severe emotional disturbance and diagnosis, our medically complex individuals, as well as our children. to see if there, potentially are other waivers that Kentucky needs to develop. Can we reconfigure how some of the waivers are managed right now to serve additional populations? Also, beginning in January, we are implementing pilots of the program of all-inclusive care for the elderly, or the PACE program. And so we we're further along in that process than we were when we wrote the initial spending plan, but we'll likely have some program management assistance just that helps with that and helps with reporting. So what is our status today? We received partial approval on September 30th. CMS requested some additional information, and really, to me, these were really just clarifications. How are we going to use acute and transition services for individuals with disabilities involved in the criminal justice system? That would be transition from criminal justice system back out into the society. One-time expenses to increase participant independence, implementation of the improved application process. This also will include looking at a new assessment tool that captures needs in a better way than our existing tools. We use multiple tools across the different waivers right now, so we're going to look at what we can do there with that assessment tool. That, again, will be a place where there'll be opportunities for stakeholder engagement, a lot of activity planning around that before we could get to a point that we would be ready to even begin to implement that. Again, talking about exploring our new rates. They wanted to know what our rate study, how we were going to do that. And then they had some questions about what we were going to use the funds for with PACE. So what have we done? We've provided CMS with the requested information. We're awaiting our final response. We've spent about the last 6 to 8 weeks developing our initial project plan for all of the initiatives. There's been assigned owners, and so it may be that an initiative is led by somebody in BDID, or somebody in Dale, or that it's somebody in Medicaid, or that there's a combination of individuals that are the leads, and then they'll have work teams under them. Some of the initiatives, the work beyond research, the research phase actually will begin in January. We're doing a lot of research right now, but the rate study in particular will kick off. You'll start hearing a lot more about it in January. But it's important to remember, full implementation is going to take time. We've identified that there are needs with the waiver that need improvements. There's changes we all want to make, but there are a lot of initiatives that are going to require waiver updates with CMS. They're going to require regulation updates. Both of those have their own very specific process and include public comment, all of which are very important. I will continue to do, as I have since I started this job, to promise to be as transparent as we can and to have as much stakeholder engagement as we can. I feel like it's very easy for me sometimes to sit behind my desk and think, oh, that really sounds like a good idea. And then, I have somebody that's either accessing the service or delivering the service say, what are you thinking? That makes no sense. So stakeholder engagement is very important to our team. And so we plan to continue that. Hopefully sometime in 2022, we can actually begin meeting face to face more versus screen to screen. So we can hope for that in 2022, but do look for more information on stakeholder engagement beginning in January. Kelly, go to the next slide. So here there's several links on the slide. I know that Kelly, did you post them in the comments or in the chat?
I will be posting them momentarily.
Okay. And as well, the presentation will be posted so that you'll be able to, don't worry about having to jot those down. Some of them already, but it just will get you to our spending plan, our approval letter, so that you can see that and talk about how to stay connected and how to give us feedback. The last thing that I want to talk about before we open it up to questions is the disaster response and what has been happening since Saturday. So DMS staff and then our partners in the sister agencies, BDID and Dale, we have been looking at the numbers of participants that have been affected, the numbers of providers that have been affected. We've talked to PDS employees. I believe the team has made an initial run through between all three agencies of at least the first attempt at contacting individuals. We still have the surveys that are out there that either provider or participant can complete, and we have staff that go through those every day and make connections and call and talk to people. I know Kelly has sent out now at least one update to a resource list so that we are trying to connect individuals to the help that they need. We are working with CMS on the Appendix K, and I actually just sent something back to them right before this meeting started and anticipate us having full approval on that probably by the end of the day today, if not first thing Monday morning, and it is retroactive back to Saturday. So now with that, we'll begin the Q&A session. So I know the instructions are on the screen there of how to do that. So the first question is, as mentioned earlier, these funds are temporary. What will happen to these initiatives? Higher rates, statewide payroll, when the funds are no longer available? That is a very good question. And that's one thing that CMS outlined in the instructions, is that what we use to spend, what initiatives we spend this money on, the state has to be able to sustain once this FMAP, so once March 31st, 2024 comes around, because the funds will no longer be there. So that's why you'll see a lot of the things that we're looking at, the rate study, the feasibility studies, the kind of one-time infusion of funds that we can do that are kind of one-time initiatives. We've been very open with the legislators. The waiver redesign task force just reviewed and approved all of the recommendations, so they will come for formal response and review. But that was just done on Wednesday, and I do believe the legislators understand the need for additional funds to be infused into the program for us to have the state dollars to do that. But we have to be very careful about what we spend this money on, because if we cannot sustain it, that's the last thing that we want to do, is say, okay, here's your increased rate, but oh, I'm sorry, we won't be able to continue that. Can you say more about the strategy for determining incentive and recovery payments to help the providers, and when might providers see these funds? We are actually working right now on evaluating that. We're looking at some of the claims data, enrollment data, and so I don't have the exact formula or really in-depth details to share, but we'll be sharing that soon, and I hope by first quarter that you all will begin to see some of that money. I'm just gonna stop my camera because I feel like I'm staring at you all. If anybody wants me to come back on camera, I have no problem doing that. But I just feel like I'm staring at you all, and I don't know. That just doesn't seem. It seems rude. And I will say, I know we've still got quite a bit of time, and we'll leave it open for questions to come in. But if you're like me, always when I hang up, I think, man, I should have asked that question. There's multiple ways for you to reach us. Plus, I'm sure everybody has my contact information, the Medicaid public comment box. You can, always after these sessions, send us those questions. And this is truly just the first session. We wanted to let you all know, kind of give you a background and let you all know that we have gotten started and that we are truly doing a lot of work. It's just not a lot that you can see yet. And that there's more to come, and stakeholder engagement will be a big part of it. I do not have any update on the rate increases right now to be able to share. I'm sorry, the question was, is there an update on rate increases? Can you tell us more about the initial plan for the feasibility study? So we will have a consultant group that will be helping us to conduct those feasibility studies. So I don't really have a lot to share. Other than, in the beginning, it's going to be research into what other states do. It'll be research into our populations, the types of services individuals are getting. We certainly will share more as those, as the plans actually start developing and we have information to share. But the beginning phase is really just a lot of gathering data to be able to start kind of answering the questions. For the one source for FMA idea is the vision to require all providers to use single vendor, or would agencies still have the option to continue to provide FMA themselves? So the plan would be, we would have, and I'm thinking it would be 3 vendors, so that we had kind of split the state in 3s, and that individuals would have the ability to choose amongst any of those. That will still be fleshed out. We really don't have all of the details yet, but we'll be sharing more information on that as we get closer to releasing information and closer to implementing and working on an RFP. Will any of the ARPA money go directly to ADHD centers in a lump sum or in a rate? So there will be, I believe, some money that will go to all types of providers, which would include ADHD centers. And I don't know if it's going to be a rate or a lump sum. I feel like it's going to be more of a lump sum versus rate, because of it being having to be sustained after March 31st. So that, and it lets us infuse the money faster versus, a rate as you bill something, that it just is more, versus us being able to give you, and I'm just going to make up a dollar amount, $500 for, giving for hiring, to help with hiring or retention. And again, that's just a number that came to the top of my head. I know that's not really realistic, but there is no time frame or the estimated amounts of payments yet that I am able to share. No need to apologize, Barbara. I completely understand. I wish I had more information to be able to share, but I will tell you that this week has been consumed with focusing on the natural disaster and addressing some of those needs. So we will get back on track with, being able to devote more time to these, to have more information to share. And I can say too, just I guess, to as fair warning to you all, as providers, it may be that we reach out to you all for some information too, to understand the impacts that you all have had, and what you all are seeing as part of that, to make sure that we get that right. So, I guess that's fair warning to expect maybe some requests from us to understand how things have impacted you all. Would a rate study have the same state budget neutrality requirements as the last rate study? So yes and no. So CMS requires us to be budget neutral. The requirements around the last rate study, and this was previous administration, was that we looked at what we currently spend on the waivers, and that we just shift dollars around from program to program to adjust the rates. That is different this time. So we always have to remain budget neutral with CMS, but the approach with the rate study will be different this time, as the administration has not constrained us to stay within that same pie that we have now. So you don't have winners and losers. We can address everybody fairly. I will tell you all, I am so excited. In the 20 plus years that I have worked with waiver programs and with Medicaid, I have never seen the opportunities that we are getting right now, and the additional funds that we are having access to, or having the opportunity to utilize. It is great to finally see some focus be given to these very, very necessary programs, and very, very important programs. Is there much utilization of telehealth? So right now it varies. It varies by area, and it varies by service. Primarily where we see it is in case management. We have seen some ADTs that have done some telehealth, but case management has been the primary area where we've seen telehealth used. You all make me nervous when you're quiet. I hope it's just because you're thinking, and I realize it's Friday at 2 o'clock after an incredibly stressful and long week. So please feel free to reach out to us after. We'll leave things open for questions to come in, but I don't want you to feel like I'm holding you hostage either. So I will go ahead and say, if we don't get to speak again, Merry Christmas, Happy Holidays, Happy New Year. Enjoy time with family and friends. And I will use something that the secretary has said to us in a couple of different meetings. Boy, I really hope that 2022 is boring, because we certainly have had a roller coaster of a ride in 2020 and 2021.
And say if people do think of questions afterwards, I put the Medicaid public comment email box address in there as well as the help desk. You can send emails to either of those. They'll get to us one way or the other. I think most of you all are pretty familiar with those emails at this point, but they are there just in case you're not. And also, I think my email was in all of your registration emails that you got. So if nothing else, if you forget that, my email's in there.
What is meant by budget neutral with CMS? CMS looks at, we have to do a report with CMS called a 372 report that looks at the cost of institutional services and services that in the institutional services themselves, as well as other services that those individuals receive, for example, hospital, physician, medication, as well. And then we compare that to what our waiver individuals, the spend for the same thing, the waiver services, and then what for their other services that they receive. And so our overall cost cannot exceed what it is for a nursing facility. And so, I will say some individuals we have on the waivers do sometimes by quite a bit exceed that amount, but because we have some individuals that use very few services, it all balances out. But we do have to remain budget neutral to keep our funding. I will also say, if you hear of anyone in any of the storm damaged areas, or just in general, if you know of someone that has a need that and they need assistance meeting it, please always reach out to us. I am blessed with an incredibly caring team that works very hard to help individuals through all kinds of different situations. So we, want to make sure that you all know you can always reach out to us if you have someone that you just you not even sure where to begin to refer them to. Reach out to us, and we a lot of times may not know the answer, but we'll work to get you connected to the right place, or to get the participant connected to the right place. Right, Kelly, I think we've went several minutes without a new question. I think that we can go ahead and close and give people a few minutes back. Again, if you think of something after the meeting, just reach out to us. look for exciting information and new opportunities to come beginning at the first of the year. And I'm really excited to see what we can do with these waivers, and to provide additional support to our provider community.
All right, thanks, Pam. So I will, again, we put some links in the chat there. I'll leave the meeting open for a couple minutes here after we wrap up, just so you can grab those links if you want, but don't feel pressed like you have to do that. I will send an email, a follow-up email with the links, as well as a copy of the presentation and the recordings from all of these meetings that we've had these last couple of days. So again, those links are there if you want to grab them, and I'll leave the meeting open for a couple minutes, but don't feel like you have to, or if you forget or something like that, we'll have them. So I think that is it. So we will go ahead and end the audio portion. Thank you all again for joining us. Hope you have a great weekend and a great holiday.